Now, I do want to make a note here. When we say radiologic technologist, we often shorten that to rad tech. Right? However, a lot of times when people see the abbreviation rad tech, they turn that tech into technician. Ah, you're a radiologic technician. Oh, you're going to be my technician for today. No, you are not a technician. In our field, when we say technician, we are specifically referring to those who repair or maintain our equipment. Okay. So technicians work with the equipment. Technologists, you're the ones who actually take the images, take the pictures. Right? So you're not interested in repairing the equipment, you're interested in using it to create X-ray images. Right? So do make sure that you remember you are a radiologic technologist and not a technician. Very common mistake. It's a public people often get them confused, but at least you, as a technologist, should know the difference. So we use ionizing radiation, hence the radiologic course, to perform radiographic procedures. Okay. Ionizing radiation basically refers to a type of energy with enough power to remove electrons from atoms inside your body. Okay? So it is more dangerous in that regards. So because this is a dangerous form of energy, though you do need to be trained in its use. Right? So to become a radiologic technologist, this requires technical skills combined with knowledge of physics, anatomy, physiology, and pathology. Out of curiosity, does anyone know what the difference between anatomy and physiology is? Yes?
Anatomy is the actual parts, physiology is like the functioning and how to do so.
Very good. So anatomy is the physical part itself, and then physiology, how it functions, how it moves, how it acts. Okay. Now, we do have radiography practice standards. These standards are given to us by the American Society of Radiologic Technologists, the ASRT. Okay, so this is our national society. These standards define the practice of radiography. They describe the necessary education that you need for certification in radiography. And this includes the radiographer's scope of practice. Okay, when you say scope of practice, we are referring to what you can do, what you cannot do. So within your scope of practice would be operating the equipment, taking images. Outside your scope of practice would be diagnosing your patient. So even though you may take an X-ray of a patient's leg, and even though it may clearly be broken in two, you are not allowed to diagnose the patient. You should not be the one to tell the patient, yes, that's right, you've got a compound fracture of your femur. No, that responsibility belongs to their physician. Right? The doctors are the ones who diagnose. You do not. So those are the sort of things that are detailed in the scope of practice. Yes?
Is that why anytime like a patient or like, let's say one of us has gone into an imaging sort of thing for one of our issues, and you ask like the technician, hey, technologist.
Thank you.
The technologist, sorry, to like, hey, like how am I looking or whatever, they just say, I don't know, like you're gonna have to ask your doctor.
Correct.
Okay,
That is
cool.
why they say that. Because asking them what's on the image, right, is outside the scope of practice.
Right.
They cannot respond.
Sir?
Yes.
But they actually know it, right, sir? They should be knowing it, right?
Sometimes they will, or sometimes you will, sometimes you won't. But your answer in all cases should be,
Ask your doctor.
I don't know, I can't say anything, ask your doctor. Maybe not the I don't know part, but at the very least, ask your doctor. I'm not allowed to say. Kind of on a small tangent here, if a patient does ask to see their images are part of their medical records. If you want, you do have the freedom to show the patient their images, but once again, you cannot tell them anything about their images. Can they take pictures of their images? No. Why? Because those pictures contain sensitive personal health information. Right? So, the best practice, in my opinion, is just to tell them that, no, when you visit your doctor, they can book the images for you, and they can explain what they see, right? So don't even give yourself the temptation of showing them the image and then wanting to explain what you see on it. Just shut it down right away. Just say, no, just wait until you visit your doctor, and they'll be able to show you your images, explain what they see. Right. In addition to that, right, we've also got clinical performance standards, quality performance standards, and professional performance standards. So all of these documents can be found on the ASRT website at asrt.org. So if you would like, feel free during the break to hop over to the website and see exactly what sort of information they lay out. Okay. As part of our profession, we deal with ethics. Okay. Ethics is our professional moral responsibility, and it's also the science of appropriate conduct towards others. Now, the ARRT is the one that creates and maintains the standards of ethics for radiologic technologists. Okay, so this is the American Registry of Radiologic Technologists. On your first day, Friday, right, when we had our orientation, we had you sign some paperwork. Among that paperwork was a sheet that was pre-clearance, ethical pre-clearance for the ARRT. And that ethical pre-clearance simply stated that if you have any potential ethics violations, make sure that you have them cleared with the ARRT before you go through the program. Because you don't want to go through the full program, get to the end, try to take your exam, and then the ARRT says, no, you have not met our ethical standards. So the ARRT is in control of the standards of ethics. The standards of ethics includes a code of ethics and the rule of ethics as well. Once again, all of this can be found on the ARRT's website at arrt.org. The ARRT Code of Ethics is a series of 10 statements. These 10 statements serve as a guide for professional behavior. So they tell you how you should act in certain circumstances. There are also 22 rules of ethics. And like I said, you can find all of these on the ARRT's website. So if you're ever unsure of how to act in a situation, this should be your first source of guidance. Because sure, your manager might tell you to do something, sure, your supervisor might tell you to do something, but in the end, it's your license, and you do need to be following this in order to keep your license. Now, beyond radiologic technology, beyond your goal as to complete this program as a radiologic technologist, there is advanced clinical practice. And when we talk about advanced clinical practice, we are referring to radiology assistants or radiology practitioner assistants. Right, so RAs and RPAs. So this is something that you could go into after the program. This is also something that falls under the ARRT. So these are radiographers who provide advanced imaging services. So requirements for practice include ARRT radiography certification, additional education, and clinical experience under the supervision of a radiologist preceptor. So you would be working directly under a radiologist in order to earn these certifications. The title of RA or RPA may only be used after passing an advanced level certification examination. So, if you do want to do something like this, step one, go through an RT radiologic technology program. Graduate, and then you would do additional education, you would work under a radiologist, and then you would go and take a second exam, a second registry, to gain certification in this advanced clinical practice. Okay. Any questions? Yes.
I'm not sure if I read this right, but I think I read in the like the patient care book that the RA position is the one that's kind of fallen out of, I guess, pursuit, I guess you would say. Like it's not like as much as like a known position anymore. I don't know if I read that right, but
let's see. So sorry, so could you repeat exactly what was that about the ordering physician?
like the position of the RA is not as so much like common anymore.
Okay, I see. So RA is, yes, so RA as a profession is not that common anymore. That is true. It is more difficult to find jobs or openings for the position of an RA. Part of it is that some locations don't know how to properly utilize RAs. Some of it is just that there hasn't been a lot of advocacy for the position. And advocacy is important because if we don't advocate for our profession, we may lose our profession to others. For example, some places have been wanting nurses to do the job of a radiologic technologist. Do nurses have 2 years training in radiation and positioning? No, they do not, right? So it's important that we push back and say, no, nurses are not qualified to do the things that we do. No, you cannot let unlicensed people attempt to do things that we do. Right? Because as silly as it sounds, there are people trying to push for these things to save costs, to find cheaper employees, right? To let people do double duty so they don't need to hire a second person. And so it is important that we advocate for our physicians and our patients, right? Because all this comes back down to the quality of patient care. Will the patients get the quality imaging they deserve? So how do we advocate? We have our professional societies, right? ASRT. We also have our state professional societies, the TSRT, Texas Society of Radiologic Technologists, right? So it is important that we do participate in these professional societies to make sure that our patients are getting the proper care and that our physicians aren't taken over by someone who is not qualified. So, yes, unfortunately, I don't think RAs or RPAs have had much advocacy, so their positions are not going to be very common. Although there are still some programs out there if you are looking to go into that field. Just know that right now, as of now, the job outlook hasn't been that great. Okay. As a radiographer, you are responsible for taking care of your exam room. So everyone has been through lab. Right? Everyone has seen that at the end of lab, we need to properly take care of the room, wipe it down, and clean it. You've all heard that at the beginning of lab. You should be looking to stock your rooms. Make sure there are enough gowns, linen, supplies for the day. Okay. And this applies to outside of lab as well. So when you go into clinic as a student or when you are working, it is your responsibility to make sure that the room is prepared. There is no one else who will do it for you. You do not want to be the tech who has a patient come into the room, you go to put a sheet on the table, and then you realize you're out of sheets. Right? Make sure that your room is stocked, make sure that your room is clean. Especially for cleaning, make sure you clean between each patient. Okay? Make sure you clean between each patient. This is important for infection control. You do not want something from patient A being transmitted to patient B. Right? Clean in between to make sure you stop that spread. And of course, make sure that your equipment is working as well. Make sure you take good care of your equipment. Make sure you warm up your equipment when necessary. Make sure that you treat your equipment with respect. So, between these two pictures, right, which room do you want your exam room to look like?
First one.
A, yes. Right? Table nice and clean, right? Tube in position, trash emptied, clean floor, step stool ready for the patient. Right? Over here, you don't want stuff sitting on your exam table. Right? Pillowcase looks wrinkled, tube remaining from whoever used it last, aiming in a strange direction. Who knows what exam they were doing? Step stool nowhere near the table, kind of useless right now, just in the way. Trash overflowing to the point where you have stuff on the floor. Even over here, right, you've got your supplies leaning against the wall instead of properly put away.
Is that a chair or a clipboard?
On
On the floor.
On the
Like in
floor.
the back- in the back?
Here?
No, behind. Yeah, like where the trash was.
Where the trash is.
That thing to the right. It's just like a clipboard.
This thing here?
You're talking about
Nothing?
On the floor.
Oh, next to the trash
Oh,
can.
this thing here.
IR.
That looks like a cassette holder. That looks like your music stand.
And what do you use that stand for, sir? The one in the front?
This?
Yeah, to raise level, height?
That's a step stool, so it helps the patient get onto the table or get off.
That-
Right, so please take care of your exam rooms. Make it a room that you can be proud of. make it a room that you would want to bring your family members into if they have exams. Right? Your own room at your house can be as messy as you want, but make sure your exam room is clean.
Wait, can
Yes.
you go back to the other side? Is there contrast in that fixture?
Contrast. Where do you see contrast?
It says maintaining stocks, linen, contrast.
Oh, I see. Okay. So, as far as contrast goes, in X-ray, we sometimes need to use contrast, which is kind of like a type of medication to make things show up on the image. And so we've got bottles of contrast in the department. So of course you want to make sure that you do have contrast in the department for when you need it. You don't want to have a patient come in for a procedure, the doctor says, all right, now let's go get the contrast, and the contrast isn't there. Right? You should have the contrast in stock and already pulled out, ready for the doctor before the patient even gets there. Right? Part of prepping your room. So that is what we mean by contrast.
Then, since you added, what is ancillary?
Ancillary equipment. So other types of equipment. So in this case, right, your step stool, right? Not directly related to X-ray, but it is a supporting equipment. IV poles would be ancillary equipment. So having an IV pole in the room, but out of the way, would be making sure that your room is ready. So ancillary equipment, just extra supporting equipment for things you might do, things you might need. Any other questions? All right. Image receptors. So you've seen image receptors in lab. Image receptors are the device which receive energy from the X-ray beam and which forms the image of the body part. So image receptors are what captures the X-rays and turns it into the image we can see. There are 4 types of image receptors. The old type, cassette with film. So when we say film, we mean actual photographic film. You would have the film inside a board called a cassette. You would shoot your X-ray. You would take that board. You would walk into an actual dark room with a red light. Open up that cassette, take your film, feed it through a processor. This chemical processor will dunk the cassette or dunk the film into 2 types of liquid, wash it out, dry it, and a minute and a half later, you will have acquired 1 image on your patient. Okay, it was a 90-second process, 1.5 minutes. Yes?
Is it cheaper than the other 4 types of, other 3 types of?
Was it cheaper? So, funny thing, the film, the photographic film that we used with this was made using silver. Silver is not particularly cheap. In fact, silver was so precious that after we used the film and it was no longer required for the patient's records, the film would be recycled just to recover the silver. So it was expensive on a per image basis. Yes, Shamika.
Question on the types of film. Will we
Yes.
also need to know what all they do as well, as far as testing, or?
So what I would say is, know that these exist, but you do not need to know the details of the cassette with film.
Okay, thank you.
Back when I was in school, we did, because that's actually what we used.
Mhm.
Nowadays, you don't. What you will end up focusing on are these next 2 items. The photostimulable storage phosphor imaging plate and the solid state digital detector. So you've got your PSP cassette, and then you have your solid state, your digital detector. these are the two that you will see in lab. The Psp plate, that was the cassette, that was freely movable, right? When I showed you the 14 by 17 or the 10 by 12, those cassettes were Psp plates. So you take those, you shoot an X-ray, you go to a processor, not inside a dark room, push it in, image comes out about 5 seconds later. Much faster turnaround time, right? No need to wait 1.5 minutes for a picture. Solid state digital detectors. These are the ones inside your Buckies, right? So you notice that your Buckies didn't have a place to put cassettes. Why? Because instead of using a Psp plate, they are using a solid state digital detector. X-ray septum, they capture the image, immediately send it to your computer, and it shows up maybe 2 seconds later. Even faster, less hassle, less parts to move around. And then we have these two over here. Portable digital radiography and fluoroscopy. Okay, portable digital radiography, kind of similar to these, but it's more like a cassette that is digital. Okay, so you shoot the X-ray, the cassette captures it, and it can just beam the information to your machine through Bluetooth or something. Fluoroscopy, this is X-rays in motion. So normally when we think of X-rays, we think of a static image, a still image. It does not move. But in fluoroscopy, what we're doing is we're almost shooting a video with X-rays. We're going to shoot multiple shots very quickly so that you can play them back and you can see things moving. Right? So those are the types of image receptors that you do need to know. We're not going to go into too much detail here. We will get a chance to talk about how they work in later semesters.
I have a question for
Yes.
about the silver thing was for with the cassettes with the film.
Correct.
Those are made out of silver, sir.
Correct. Those are made out of silver. These other ones used different materials. They're more expensive up front, like to buy a solid state digital detector costs more than buying a film, but they're multiple use. So over their lifetime, they cost less.
What was the specificity for the solid state digital detector again? Like
So-
you said, what they're able to do?
So solid state digital detectors, you basically don't need a processor.
Okay.
It automatically processes the image itself. So with your Psp, right, you shoot the picture. Actually, I've got one right here. So I got this right. Shoot the X-ray. Gotta walk over to this machine. Stick it into the machine. Goes beep boop. Okay. About 5 seconds later, image pops up. About 15 seconds later, it pops this back out for me to use again.
Okay.
That's Psp. Digital detectors. If this was a digital detector, X-rays, image. Great, let's do the next one. X-ray, image, next one. X-ray, image, right? I don't need to go to an actual processor to get my image out. It will automatically create the image for me. So much more convenient, much faster. Yes?
So with that one, you only do one image at a time.
Correct. With the Psp, we can only do one image at a time. So in the old days, if I wanted to shoot 3 images, I'd carry around 3 of them. Put one here, X-ray, all right, change it out. X-ray, okay, change it out. X-ray. Then I run to my machine, stick it in, stick it in, stick it in. That's how we used to have to do it. If you did portable X-rays, where you're driving around with a giant X-ray machine, they used to have this slot that you could pull out. In fact, you go over to our room across the hall, and you can see this. The machine had a slot you can pull out. You take all of those PSPs, shove them in there, go do 10 patients. So with your 10 PSPs, then hopefully you remember which ones goes to which patient so that you can send them across properly. Right. Nowadays, with portable digital radiography, we don't need to worry about that anymore. You just put it underneath, X-ray, immediately goes to your machine, check your image, send it across. Right. Wi-Fi, Bluetooth, wonderful technologies. Okay. Any other questions? Right. So here's an example of cassette with film. Right. So this is the film that silver in it. You accidentally expose this to light, and your film is wasted. We had to keep it securely inside this cassette here, and we could only open it in the dark room under red light. If anyone has done film photography, right, very similar process. Here is our Psp Imaging Plate, right, just like the ones I showed you now, or the ones that you've seen in lab. Here, solid state digital detector. Right. So, our bucky, right? Go into the machine there.
What bucky is this, sir?
A good question. Let's take a look. What bucky is this? This looks like a
The wall
very
bucky?
old wall bucky.
But not like the one we had, the nice slim one.
No, this. I mean, you can tell because you look over here, you see an old
Ooh.
CRT TV, right?
Yeah.
You don't see these boxes anymore. You've got flat screens. So you know this is an old picture,
Moved it on the wall.
right? So this is what we used to have in the old days.
Mhm.
Actually, we didn't even used to have this because back then we still had film. Only fancy places had things like this,
We think it's more than TV or the actual.
right? Yeah, that's an actual TV. Who would have thought? Okay. Here we have one of those portable digital cassettes. This one doesn't use Bluetooth, so it's got a wire attached to it to send information to the computer. Right, but you don't need to run this through a processor, right? You just leave it under the patient, and you can shoot as many X-rays as you want. Wireless DR. This is the stuff, this is my favorite type. Right? Take this, stick it under the patient, no wires, just shoot your X-rays, immediately goes to the machine, no interaction required. Only issue with wireless stuff is that it runs off batteries. So you do need to make sure that your batteries stay charged. Nice thing about these is that once your battery starts draining, you just swap it for a new one. If only electric cars were that easy. These use much smaller batteries, which is what makes that possible. And then we have fluoroscopy. Now, we haven't really seen fluoroscopy in lab yet. Okay. But at LBJ, we do have a fluoroscopic department, and these machines are what shoot X-rays in motion. So they have a continuous beam of X-rays that are on, and then as you move things, you will be able to see the motion on the screen. Okay. So, when do we use fluoroscopy? In this case, we mainly use them for GI studies of the gastrointestinal system, right? Basically your digestive system. So, if you come into the hospital and you're complaining of heartburn, they may order a fluoroscopy study to watch as you drink contrast. And so remember earlier when we talked about contrast? They'll have you drink some contrast, they'll watch it go down, and then they'll see if the contrast comes back up, right, to indicate that you have reflux. That would be how they would diagnose it. So, in order to do that, we need to see things in motion, and that is the purpose of fluoroscopy. digital fluoroscopy, even fancier technology. And so back in my day, we had this, but some places now have digital fluoroscopy. The idea is the same, it does the exact same thing, but it uses digital technology instead of analog technology. So it's smaller, it's more compact, but the whole purpose is the same. And now we have some of our accessory equipment. Right? So you could also consider this to be ancillary equipment. For example, we have positioning aids. Right, so for our positioning aids, down here, you will see a bunch of different sponges. These sponges are what we call radiolucent. Radiolucent just means X-rays can pass through and they will not show up on the image. So, if you needed to put something at an angle, right? If instead of me laying on my back, you wanted me to turn halfway onto my side, right? It's hard for me to stay halfway on my side. But I either want to be all the way on my side or all the way on my back, not halfway. To make it easier, you could put one of these wedges under the patient's back to help support them. Over here, we have something that looks like a staircase. This is used for things like hand X-rays. For the hand X-rays, you've got 5 fingers, right?
Mm-hmm.
If you want to see a picture of the hand from the front, right? Easy. If you want to see a picture of the hand from the side, what happens to the fingers?
See
They're
all of them.
hidden.
You only see one.
We can't see them on.
Right, they overlap, right?
Mhm.
You can't tell them apart. So we have to spread the fingers out like this.
Mhm.
This staircase makes it easy for the patient to spread their fingers out and rest their fingers here.
So staircase is also a sponge.
It is also a sponge, yes. And it also lets X-rays through, so you won't see the staircase on the image, but you will see the hand in proper position. So these are all extra things that the department may have to make things easier. Now, some departments will not have these. Right? So in that case, you will still need to know methods of positioning your patient without the use of positioning aids.
Yeah, I was just going to ask you, is this something new? Because with my broken finger, I never used a staircase for an X-ray.
Right. I only seen the staircase placed in one location, and I don't even know if it's there anymore. So yes, you will need to know how to do it without these aids. These can help, but you should be a professional and be able to do without this extra help, right? These are extra types of equipment, accessory equipment. Not everyone is willing to buy this extra stuff. Okay. Over here, we have grids. We're going to talk a lot more about grids in the fall and the spring. All you need to know about grids right now is that they are an extra type of equipment that would go on top of your cassette or on top of your image receptor. And it makes your pictures look better. Generally speaking, grids are a good thing. And then over here, we have compensating filters. We're going to talk a lot more about these in the fall, so please don't forget about them. Compensating filters are also used to improve your image. The idea is that your body has different thicknesses, and X-rays change appearance based on body thickness. For example, if you have bone, right? Bone shows up bright and white on X-rays because it's thick, it's dense, it's hard. If you have muscle, fat, or something even less dense, like your lungs, air, right? Air shows up black on X-rays because it's so thin. X-rays just pass right through it. So if you have something that is a mix of thin and thick, you will get an image that looks different on one end compared to the other. The purpose of these compensating filters is to prevent the image from looking different by adding some extra thickness to your thin part. So it's compensating for the change in thickness. Right, so compensating filters. Yes?
Where would an example of that be? I know you mentioned the lungs, but would that be used there? Or?
So most likely not. The most common example would be the foot. Because if you look at your foot, toes, very thin, right? Ankle, thick. Right? You go from thin toes to thick ankle. So, in order to compensate for that thickness, you would use one of these, put the thick part of the filter at the toes, put the thin part of the filter at the heels to balance out the thickness.
These are used as support or display of the thing where you're going to take the pictures.
So this is used to improve your picture quality. It improves how your picture looks. But it is not used to help you position the patient. It is not used to help support the patient. It is only going to change the look of your image. All right, so let's talk about the general steps, how you kind of go through your workflow. So radiographers, we follow a set of common steps for each radiographic procedure. So it doesn't matter if you're doing a hand, a foot, a chest, a pelvis, a spine X-ray. You want to follow this order in general. Right? This improves your efficiency. This improves patient safety. This reduces mistakes. This minimizes patient exposure. Okay. Now, the order of these steps may vary slightly depending on what anatomy you're looking at, or the condition of your patient, if they're healthy or if they're unstable, what types of equipment you have available to you, and even the protocol for your department. Do they ask you to do specific things? But generally speaking, we have a set of common steps that we want to follow. All right. Over here, we have something called an exposure technique chart. So technique charts should be in every room, and they should be on mobile machines. Some of you in lab may have seen the technique chart next to the console. So in the lab room, we had our console with the on-off button, we had the console with the X-ray button, and off to the side, there was a small technique chart. And all rooms should have a technique chart. These technique charts are specific to that equipment in the room. They are specific to the type of procedure, the type of projection. And they, right, so when we say procedure, right, okay, chest X-rays, projection, are we doing a PA chest X-ray? Are we doing a lateral chest X-ray? Okay, and room, right, which kind of equipment are you using? Because depending on your equipment, those numbers might change. Maybe the equipment is more efficient, so you need less power to create the same X-ray image.
So, sorry, I didn't get it. This chart would be where the tube is,
So this chart should be by the console.
where the technologist stands and takes the X-rays.
Correct. So by the monitor and by the console. So behind the window. So this is not something that the patient will ever deal with. It should not be something that the patient ever sees. Okay? This is going to be in the back by the console and by the monitor. All right, now I've got a lot of fancy vocabulary here. Don't worry too much right now. We will end up covering this later this semester. So primary factors need to be taken into account to establish the correct foundational technique for each unit, each piece of equipment. So, what sort of things can you change at the console which will affect your image, affect your x-rays? There's something called milliampere seconds, your mass. Okay. We're not talking about like kilograms mass here, right? We're talking milliampere seconds. We have kilovoltage peak, kVp. We have automatic exposure control, AEC. We have the source to image receptor distance, SID. We have relative patient or part thickness. We have grids, like we mentioned earlier, under our extra additional equipment. We have CR or DR exposure indicators, or other digital exposure value estimates. We have the IR, the image receptor, or our collimated field dimensions, like the size of our light. We have electrical supply characteristics, phase, frequency, things that are determined by the generator being used. And remember, in lab, the generator was that big cabinet-looking thing in the corner. So all of these will affect that exposure technique chart. And so that's why it is specific to the equipment. It is per row. Okay, any questions?
And this is where the equipment is, sir.
So the exposure technique is where your console is.
Also, it's,
Right, this is all, right now this is all dealing with your console.
oh, I see.
Yes.
When it says the CRDR,
Yes.
is that computed radiography?
Very good. So the CRDR here, right, we're not referring to central ray.
Yeah, it's
Ins-
confusing.
Instead, we are referring to computed radiography and digital radiography. So computed radiography is going to be dealing with the Psp plates. Right, these things here. And then you've got your direct digital or indirect digital radiography, which were those solid state detectors or those digital portable detectors.
What does it mean by relative patient?
Relative patient or part thickness.
That's
So-
what we just talked about, right?
So in this case, we kind of like expect a foot to be a certain size for the average patient. We expect a chest to be a certain size for the average patient. But maybe the chest is a bit bigger than average. Maybe it's a bit smaller than average. So there's going to be adjustments on the chart based off the average. We'll say for your average patient, use this. Above average, use that. Below average, use something else. Does that make sense? Right, so just relative to your average patient. Okay, any other questions? Gonadal shielding. What are gonads? Has to deal with the reproductive system. Very good. So the gonads are reproductive organs. So testes or ovaries. So when practical, gonadal shielding should always be used. We want to protect the reproductive organs. So guideline from the Center for Devices of Radiologic Health. When the gonads lie within or close to the primary X-ray field, you should use gonadal shielding. Right, so as long as your light is within 2 centimeters, or sorry, 2 inches, 5 centimeters, you should be using shielding. if the clinical objective of the examination is not compromised, you should use shielding. What does that mean? It means that you should shield as long as the shield will not get in the way of your exam. So if I am doing a chest or I'm doing a head x-ray, I am far away from these gonads, correct? So there is going to be no issue. It's not going to affect my exam if I put a shield here in front of the gonads. So put a shield in front of the gonads. On the other hand, if I am doing a pelvic x-ray, if I try and put a shield in front of the gonads, it is going to be in the middle of my light. I will not be able to see anything on that x-ray. So in that case, we would want to move the shield. We might not want to use that shield in that case.
Would they sign additional forms or whatever to say like we are not liable for whatever damage they may sustain to gonads? Or...
Good question. So the only time a patient, at least here at Harris Health, so speaking for Harris Health protocol specifically, it might change depending on where you are. But for Harris Health, the only time we really have them sign off on a form dealing with radiation is if we have a patient that we suspect could potentially be pregnant and they do not wish to wait for official evidence of pregnancy. So for example, patient comes into the hospital, we ask them, when was the last time you had a period? Oh, well, 1.5 months ago. All right. It's been a long time. Potentially could be an issue. All right. Well, in that case, we would like to order a pregnancy test on you just to make sure you are not pregnant. No, I don't want to wait. I want my x-ray now. Okay. Well, in that case, allow me to explain the risks of getting an x-ray. And then I'll have you sign this waiver that says you did not wish to wait for a pregnancy test, you wanted to get the x-ray now. And that's pretty much the only situation I've seen where we've actually needed a patient to sign a waiver.
Okay.
But once again, it will vary depending on where you work because different places will have different protocols. Okay. Speaking
So
of which,
what
yes.
is the risk of not shielding the gonads?
Okay, what are the risks of not shielding the gonads? That is a question which takes a whole semester to answer
Awesome.
because we have a whole course, radiobiology, dedicated to answering that question and more. But the general answer, so very short answer, is that anytime there is radiation exposure, you run the risk of cancer, you run the risk of mutations. It's a very low risk, but the risk is there. Certain things increase the risk. For example, cells which are dividing very quickly have a higher risk. Cells which are immature, which have not developed specific functions yet, have a higher risk. What has cells which are both dividing rapidly and are immature? Well, babies, embryos. Right? Embryos have rapidly dividing cells, and the cells have not formed into specific organs yet. So they are at higher risk for things like cancer and mutations compared to normal cells. Once again, the risk is very, very low, but the risk still exists. Okay, and so that is why we also want to shield patients with reasonable reproductive potential. Now, right, remember, this is when practical, because here we are following the principle of ALARA, as low as reasonably achievable. If it is impractical to shield, then it is okay not to shield. Okay. But you do want to shield whenever possible. Yes, John.
Like you said, if the X-ray is in near your pelvic area, or can you put a gonad shielding on your chest, or is that only for?
Right. So in that case, there are no gonads up in the chest area. So normally we do not shield. Shielding is specifically normally for the gonads. Now, there are some exceptions. Depending on where you are and the type of radiation you're working with, you may have thyroid shielding. Thyroid is up in the neck. It's a somewhat radiosensitive organ. It's somewhat more affected by radiation. So we may have thyroid shielding. But generally speaking, we're specifically focused on shielding the gonads. Yes.
When it says reasonable reproductive potential, does that mean like your elders, you wouldn't put like a vaginum?
Right, so it would be less important to shield patients who are older. So if the patient is past menopause perhaps, then it is less urgent to shield that patient. So if you feel that it's going to be impractical, then it's much easier to decide not to shield in that case. Yes?
At what age is that?
So that depends on your patient, but generally somewhere between 45 to 55 years old. So just ask the patient and they'll let you know if they are postmenopause. Yes?
With regards to asking the patient, is that something we ask like, hey, would you prefer to use this sort of shield, or are you okay given that you are past these age of or time of risk, I guess?
So personally, I do not ask the patient's opinion on shielding.
Okay.
I would use my own best professional judgment,
Okay.
which would just be to shield everyone unless it is impractical.
I see.
So even if the patient was 80 years old, if they were healthy, fit, able to walk around okay, I would throw a shield on that patient. Okay. Better safe than sorry.
Right.
You never know. Yes, Christine?
I just had a quick story to share. Recently, someone that I know did an x-ray on a patient, but did not bother shielding the patient, and did not bother asking if the patient was pregnant. And long story short, everybody got involved and went all the way up to big management, and the person ended up getting fired. So never assume.
Very good cautionary tale. Yes.
Never assume the age, you mean, ma'am?
Never assume that they're not pregnant, that it's okay not to shield. Shield everyone, unless it's getting in the way of your image.
Yes, Samantha.
Yes, just a question, just for us as RTs. I remember when I was kind of speaking to like two RTs who were kind of older, they said because we're in the field so much, even though we're like very minimally dosed and stuff and all that stuff, and we have our dosimeters and all that, they said something about like thyroids for RTs kind of tend to go out, so some people do the shields and stuff. I'm just wondering, is it common if people are using like mobile units in the hospital, like in the ER, are they having the thyroid shield for themselves and stuff like that? Do you see any techs that are just like religious, kind of like wearing it?
Mm-hmm. So the most important time to be using a thyroid shield is when working with fluoroscopy, whether it's in the fluoroscopy unit or if you're in surgery or IR using a CR. Because in those situations, you are working close to the machine and the machine is on for a longer period of time, which means higher doses. So in those cases, yes, I would religiously wear a thyroid shield. When you're working with patients in the room, you're going to be back behind the wall, so you're going to be receiving a very minimal dose. It is not necessary. When working with portables, the key is to stand 6 to 10 feet back from the portable machine, stay away from the X-ray source, make sure the source is not aimed at you, and you should not need a thyroid shield. Now, if you're standing next to the patient when you shoot your X-rays, then you would want to shield yourself. But under normal circumstances, you should not need that. Only in high dose environments like fluoroscopy, surgery, or interventional radiology. Yes, Shamika.
Oh, question. Say if you are giving a patient a shield and they refuse, you know, they say, "Oh, I don't need it. I'm da-da-da." Do you have them just sign a refusal form, or still tell them it's best for you to have it do the policy?
Okay, so there is no refusal form. I would encourage them, or try and encourage them to wear the shield, but if they refuse to do so, and if I judge that there likely isn't going to be any harm, so I know that the patient's not pregnant based on their age or based on the fact that they actually have a pregnancy test in the system, then perhaps I would forego the shield. But I would try and get the patient to wear the shield if possible. So yes, I've had a patient say, no, I don't need that, it's okay. I'm already past the age of, no, just let me put this on you, just to be safe.
So
Yes.
we can document that, right? Like the patient refused?
Yes, so documentation is important. So if there's ever anything in the exam that is unusual or out of the ordinary, then you would document that in the system. And I don't mean like something you see in the picture, right? Because that's for the radiologist to deal with. But something that may have happened during the exam, you would want to document. Like, oh, patient was not able to stand up for the exam, so I had to do the patient's setting, right? You could document that, right? Patient refused to wear a shield, you could document that. Patient refused the X-rays halfway through, you could document that. So documentation is important because it leaves a paper trail of what happened during that examination. And so, because nowadays, most of our paperwork is in electronic systems, you would go to the computer and document that in the computer. Kind of going off topic here, but I used to work with this tech who would document basically anything that happened, and he would have the most colorful documentation. For example, he would go up to do a portable X-ray, and then 10 minutes later, I'll check the computer and I'll see about a paragraph long. That's like, went to the patient's room, tried to find a nurse was nowhere to be found, went to the patient said F you, written out for me, okay? Decided to leave, we'll come back later. He would document everything. So do not be afraid to document, because documentation is the paper trail showing what you tried to do and what happened.
I know exactly what you're talking about.
I'm sure you did. Yes.
So it's safer to document everything than to document too little?
It's
Yes.
better to document too much than too little. Yes.
Always CYA.
Yeah.
Yes. Always CYA.
Cool.
What is
Cover
the,
your rear.
what's
Cover
the,
your ass.
Oh, you said that, okay.
Didn't want to use the word, but
Yeah.
okay, I appreciate that, Jay. Thank you.
Just to, honestly open.
All right, so right now it is 9:10. Let's take a 10-minute break. Coffee break, rest.